All right, when it comes to head and neck pathology, the pharynx is one of the most complex areas you'll encounter. And let's be honest, getting the report wrong here can have huge consequences for a patient's treatment. So today, we're going to walk through the CAP protocol for pharyngeal cancers. Think of it as our roadmap for creating reports that are not just accurate, but genuinely useful. Let's dive in.
First things first, before we even talk about the cancer, we have to understand the lay of the land. You see, the pharynx isn't just one single thing. It's actually 3 different zones: the nasopharynx, the oropharynx, and the hypopharynx. And why is that so important? Well, because a tumor in one of these spots behaves and is staged completely differently from a tumor in another. The CAP protocol is what gives us the framework to navigate all this complexity with real precision.
Okay, so before we even lay eyes on a single cancer cell, our very first job is to understand the scope of what we're doing. We've got to be crystal clear about what this protocol is for and, just as importantly, what it's not for. And this is a really big deal because it sets our boundaries right from the start. You know, this protocol isn't a one-size-fits-all thing. It's specifically for resections, where we have the whole tumor and can assess everything. Those tiny diagnostic biopsies? Nope, not covered here. Specimens from a patient who's had therapy and has no cancer left? Also not covered. This tight focus is how we ensure we're collecting complete, standardized data. It's also why we stick to carcinomas and melanomas, because things like sarcomas and lymphomas have their own dedicated protocols.
So, now that we confirmed we have the right kind of specimen, our focus can zoom right in on the primary tumor itself. This is where we start to build the core of our pathology report, one critical piece of information at a time.
First up, location, location, location. And I really can't stress this enough. You have to be precise. It's not good enough to just say oropharynx. Is it the palatine tonsil? Is it the base of the tongue? And the reason this matters so much is that the exact subsite is the very first key that unlocks which staging system we're going to use later on.
All right, next, we have something that sounds simple but is incredibly powerful: tumor size. We're just measuring the greatest dimension in centimeters. But this single number is a cornerstone of staging. It directly feeds into the PT category. I mean, we're talking about a few millimeters making the difference between a T1 and a T2 tumor. And that has a huge impact on prognosis and the patient's entire treatment plan.
Okay, now for the fun part, looking under the microscope to figure out the histologic type. The CAP checklist has a whole long list of possibilities, everything from minor salivary gland tumors to neuroendocrine carcinomas. But for what we see most often here, squamous cell carcinoma of the oropharynx, there's one question that changes everything: its relationship with HPV.
So this really gets to the heart of it. For any oropharyngeal squamous cell carcinoma, the first, most critical question is it driven by HPV? We typically use a test called P16 as a surrogate to figure this out. Now, this isn't some minor detail. It is a fundamental fork in the road. Answering this one question determines the staging system, the prognosis, even the therapies. We're basically dealing with 2 entirely different diseases. So, we've identified what kind of tumor it is, but the protocol doesn't stop there. Next, we have to figure out its biological behavior. You know, just how aggressive is this thing likely to be?
And that brings us to histologic grade. Basically, how much do the cancer cells look like their normal counterparts? But, and this is a huge but, we only apply grading to HPV-independent tumors. So why the exception? Well, for the HPV-associated cancers, that HPV status is such a powerful predictor of behavior all on its own that the traditional grading system just doesn't add much useful information. Okay, now these next 2. These are things you should have on your radar constantly: lymphovascular and perineural invasion. The best way to think of these is as documented escape routes for the cancer. When you see tumor cells hanging out inside a vessel or wrapping themselves around a nerve, that's a massive red flag that this cancer is aggressive and has a much higher chance of spreading.
Yeah, and this quote right here from the protocol notes, it really hammers home why PNI is such a big deal. Finding and reporting PNI isn't just about ticking a box. A positive finding directly signals to the clinical team that this is a high-risk situation, and it can be the single factor that pushes them to recommend more aggressive treatment like chemoradiation.
All right, so we've got a solid profile of the tumor itself. Now we're going to zoom out a bit. We need to look at the tumor's edges, the surgical margins, and then figure out if it's started to spread to the nearby lymph nodes. You know, with modern techniques like transoral robotic surgery, surgeons are giving us these beautiful, intact specimens, and that makes our job of assessing margins more important than ever. Is the tumor right at the inked edge? If not, great.
But how close does it get? Reporting that distance to the closest margin in millimeters gives the surgeon and the radiation oncologist absolutely vital information for planning what comes next. And that leads us to what is really the million-dollar question in all of head and neck cancer. What is the status of the regional lymph nodes? Answering this is one of the most powerful things we can do to predict a patient's outcome. Right, so when we get that neck dissection, it's a really meticulous process. The surgeon helpfully labels the lymph nodes by specific levels. Our job is to go through it, level by level, counting the total number of nodes and, of course, how many of them have cancer. This isn't just busy work, you're essentially creating a detailed map of the cancer spread, which is absolutely essential for getting the end stage right.
Now, whenever you find a positive lymph node, your brain should immediately switch to looking for one thing in particular: extranodal extension, or ENE. This is when the cancer has literally broken out of the lymph node and is now invading the soft tissue of the neck. It's a sign of a really aggressive biology, a tumor that can punch through natural barriers. And for HPV-independent cancers, finding ENE is a major, major red flag that automatically kicks the disease into a higher stage.
And now we've reached the final act. This is where we pull it all together. We take every single one of these data points we've so carefully collected, the tumor size, the nodes, ENE, and we synthesize them into the final pathologic TNM stage. You see, staging isn't something you just pull out of thin air. It's the logical conclusion based on all the evidence you've gathered. First, you figure out the PT based on everything you know about the primary tumor. Then you figure out the PN from all your data on the neck dissection. And then, and this is the most critical step, you apply that information to the correct chapter in the AJCC staging manual. And this is why that last step is so critical. Just look at this table. You just can't swap these staging systems around. For an HPV-positive tumor, the end stage is all about the number of positive nodes. But for an HPV-negative tumor, the mere presence of ENE can dramatically upstage the disease. Use the wrong table, you get the wrong stage. It really is that simple. And speaking of using the right map, it's also about using the newest map. You've absolutely got to stay current. This latest CAP protocol, version 5.0, specifically brings in the brand new AJCC 9th edition staging for nasopharyngeal carcinoma because it reflects the absolute latest evidence for that one specific site. So look, if you only remember 3 things from all this, make it these. First up, for oropharyngeal tumors, HPV status is the master switch that controls everything that follows. Second, for HPV-independent tumors, ENE is an absolute game changer. And finally, you have to use the right map for the right territory. Know which AJCC staging system to use based on the site and the HPV status. If you can lock those 3 things down, you are well on your way. And that kind of leaves us with a final thought to chew on. All this meticulous work we do, following this protocol, collecting all these standardized data points, it's not just about helping today's patient. We're building the massive data sets that researchers are using right now to develop tomorrow's treatments. And it really makes you wonder, right? As we learn more and more about tumor biology, which one of these data points that we collect every day will be the key that unlocks the next generation of targeted therapies?